Good afternoon. My name is Laurent Castera. I'm a hepatologist based in Paris, Hôpital Beaujon, and professor of hepatology at the University of Paris-VII. So my task within the next 20 minutes will be to deal with how to integrate NASH assessment and management into the care of diabetic patients. So Mr. N, 55 years old, is type 2 diabetes with abnormal liver tests. Is a typical patient we're seeing in our patient clinic. Type 2 diabetes is treated with metformin. Dyslipidemia is treated with statin. The weight is 100 kg, is 170 centimeter high, so the BMI is 41.3. Worst circumference is 120 centimeter. He has no signs of chronic liver disease. He has mild abnormal liver tests, as I mentioned already, AST 52 unit, ALT 37, GGT 120, normal bilirubin level. Platelet count is normal, 150, prothrombin time also 95%. A1C is 8%, HDL cholesterol 0.30 gram per liter, triglyceride 2.2 gram per liter. Ferritin is elevated, above 800, but saturation of transferrin is normal, and he has bright liver on ultrasound. So fact is, in the current practice of most endocrinologists or diabetologists, liver is not in their radar. They're used to check for microvascular complication, including eye, kidney, nerves, and macrovascular complication, including brain, stroke, for instance, myocardial infarction, or vascular disease, but liver is not on their radar. However, the prevalence of NAFLD in type 2 diabetes patients has been shown to be high as 55% in this meta-analysis from Dober-Younossi. 80 studies, almost 50,000 patients with type 2 diabetes, and this is twice higher than would be expected in the general population. Now, if you look regarding the prevalence of severity of NASH and advanced fibrosis, you can see that the number of studies dramatically decreased because of liver biopsy, and still the prevalence of NASH is very high, close to 70%. And the estimated prevalence of advanced fibrosis is 17%, but this is based on 7 studies only, with less than 500 type 2 diabetes patients with liver biopsy. And you see that the confidence interval is very broad. So there are many limitations. Population-based epidemiological studies are weakened by the absence of liver histopathology. On the other hand, studies based on liver histopathology are limited by small sample size, spectrum bias, varied case definition, and unclear indications for liver biopsy. So that's the real prevalence of NASH and advanced fibrosis in patients with type 2 diabetes remains poorly known so far. So I would like to introduce a QUID NASH program. The objective of this study was to prospectively assess the prevalence of and features associated with histologically proven NASH and advanced fibrosis as possible indicator for the need of further liver assessment. So we have enrolled 713 type 2 diabetes patients with NAFLD seen in 4 outpatient clinics, of whom 130 underwent a liver biopsy. I want to stress that the indications for liver biopsy in this cohort, first, were standardized, second, not based on pre-selection with non-invasive tests, which is quite unique. The indication was based on abnormal liver test, that is persistently elevated ALT, above 20 international unit in female and 30 international unit in male. And of course, no other cause for liver disease. When we look at the result, you can see on the left on the slide, the prevalence of NASH was 58%. So in keeping with what has been reported before, but the prevalence of fibrosis, you can see the different stage going from F0 to F4. And to make a long story short, the prevalence of advanced fibrosis, the most important endpoint, because this is related with liver-related event, liver mortality, and all-cause mortality, was above all 38%, including 10% with cirrhosis. This is in an all-comer population seen in diabetes clinic in France. Now, as for the prevalence of at-risk NASH, that is NASH and significant fibrosis. This was 40% in this population, and this patient would qualify for pharmacologic treatment when a drug is approved. So what about screening diabetic patients for NAFLD? The recommendation in the literature, as you can see, are conflicting. Some, as the joint EASL-AASLD guideline published now 6 years ago, are in favor of screening systematically type 2 diabetes patients. And also more recently, the ADA guideline in 2020 provided similar recommendation. On the other hand, the latest AASLD guideline were against systematic screening as the NICE guideline in the UK. However, if you look in this meta-analysis published 2 years ago, patients with type 2 diabetes have a twofold increased risk of severe liver outcome. Also, as I mentioned before, advanced fibrosis is a major prognostic driver in NAFLD, both for liver-related mortality and all-causes mortality. And this is the latest and the largest study to date, prospective from the NASH CRN, with a median follow-up of 4 years. So clearly, if we want to screen diabetic patients, we need to create pathway between primary care and liver clinic. And in the general population, of course, the risk factors for NAFLD are well known, apart from type 2 diabetes, of course, age above 40 years, obesity, and more generally, features of the metabolic syndrome. Most of these patients are seen in primary care, where the prevalence of advanced fibrosis is much lower than in the liver clinic, below 5%, probably around 2 to 3%. And for this, you need to start with a very simple test, easily or widely accessible, very cheap. And the best tests that qualify are serum biomarker. And among serum biomarker, FIB4, that is composed of age, transaminase, and platelet count. And if FIB4 is below 1.3, the likelihood of having advanced fibrosis is very low. And these patients do not need to be referred to a specialist. On the other hand, if FIB4 is above 1.3, they should undergo a second examination. And the most popular one is transdental elastography, better known as FibroScan. And so far, this is mostly available in liver clinic. But what about diabetes clinic? Prevalence, as I've shown, is probably higher than anticipated, and it's in between primary care and liver clinic. And these patients should be screened systematically, and pathway need to be created. This is the EASL algorithm that has been proposed for detecting advanced fibrosis in NAFLD. So again, as I mentioned, FIB4, and if you're below 1.3, no need for referral, lifestyle modification, and you can retest, of course. If you're above, you should undergo a second exam. The first one is liver stiffness, and the cutoff is 8 kilopascal. And you might use a second test, a patented serum test, and combine them. And when, of course, then in concordance, the likelihood of advanced fibrosis is very high and don't need a liver biopsy. In the other cases, you might consider liver biopsy. The interesting thing, these guidelines from EASL were published in September 2021. And since you can see that many other guidelines, these are the guidelines from QUID, from the endocrinologists, published this year, and they go in the same direction. The only difference is the dual cutoff strategy instead of a single cutoff. But you can see that the field is aligning. And we have also this recommendation published in Gastroenterology from AGA that use basically the same pathway, FIB4, then liver stiffness. So back to our patient, you can see the FIB4 is above 1.3, CAP is suggestive of steatosis, and liver stiffness is elevated above 10 kilopascal, 12 kilopascal. This is a paper from the group of Quentin and Steve showing the result of the EASL algorithm in type 2 diabetic patients seen in primary care. And they started with a FIB4, as you can see, and less than 20% of the patients had FIB4 above 1.3, but 25 were not referred for transdental elastography. And out of 86, only 58, so 12% of the total, underwent transient elastography. The majority, as you can see, around 40%, had liver stiffness below 8 kilopascal. But as for the other, it failed in 5 cases, and the other range between 8 and 15 or above 15. At the end of the day, you can see only 20 patients, so less than 5%, had a new diagnosis of advanced liver disease following specialist review. So this algorithm does not seem to be perfectly suited for type 2 diabetes patients. This is our experience in QUID NASH cohort I've already presented. Using EASL algorithm, you can see that you end up with false negative for advanced fibrosis in 27% of cases. And if you perform a FibroScan in patients above 1.3, again, you end up with false positive in a little bit more than 30% of cases. So again, suggesting that this algorithm is not optimal in type 2 diabetes patients. One of the issues is that transient elastography availability is limited in most diabetes clinic, and also awareness regarding non-invasive tests is usually poor among diabetologists. Finally, very few patients with NAFLD are currently referred to an hepatologist for further assessment, and opportunity for early intervention are missed. So in order to address this limitation, the fact that most diabetes clinics currently do not have available or accessibility to FibroScan, we designed a very simple score based on multivariate analysis in our populations to be able to identify patients with advanced fibrosis that should be referred to an hepatologist. So this score, as you can see, includes FIB4, so age, transaminase, platelet count, and metabolic parameter, waist circumference, HDL cholesterol, and GGT. And you can see that the OROC of this score was 0.77 in our population. Now, if we go back to our patients, waist circumference was 100 centimeter. You can see transaminase, platelet count, HDL-C cholesterol. So you can go online with the scores, and then you enter the age, the different other parameters, as I mentioned in our patients. And you can see that in this patient, the risk for having advanced fibrosis was 90%. So very high. And these patients should be referred to the hepatologist. Actually, this is what has been done. A liver biopsy has been performed. And as you can see on this slide, he has cirrhosis and a SAF score of S2, A3, F4 with a NAS of 4. So would be a candidate for pharmacological treatment once the drug is approved. So just to conclude, I hope I convince you that close collaboration between diabetologists and hepatologists is critical for our patients in terms of management, but also in terms of awareness. Thank you very much for your attention.